When I started working in a long term care facility, restraints were freely used, and I'm not telling you my age. But just like surgeons don't automatically remove a child's tonsils anymore, times have changed. And that is what we're going to talk about today. So, the objectives of this teaching are the following: describe the different types of restraints, their impact, the dangers and adverse outcomes, myths and misconceptions, legal and legislative aspects, and alternatives to restraints. So, what comes to mind when we think of restraints? The immediate image that came to my mind was somebody in a straitjacket. However, there are many different types of restraints. Literature explains different types of restraints, namely physical, chemical, seclusion, and environmental. A physical restraint is defined as any manual method or physical or mechanical device, material, or equipment attached to or adjacent to the resident's body that the individual cannot remove easily, which restricts freedom of movement or normal access to one's body. This includes leg restraints, arm restraints, hand mitts, soft ties or vests, lap cushions, and lap trays the resident cannot remove easily. And keep in mind that this definition does come from the Center for Medicare and Medicaid Services. They also define a chemical restraint as any drug that is used for discipline or convenience and not required to treat medical symptoms. Seclusion is defined as placing a person alone in an area with the doors shut in such a way as to prevent free exit from that area. And an environmental restraint is predominantly used to prevent free movement of a person in a building or an area. We're mostly just going to talk about chemical and physical restraints today. Now, chemical restraints are used in nursing facilities to sedate or pacify patients whose behavior is too aggressive or unruly for the staff. When medications are used to treat illnesses or protect the safety of a patient, they do not qualify as chemical restraints. The usage of chemical restraints is a violation of federal law. So any type of drug that has a calming or disorienting effect can be used as a chemical restraint. Some of the most common types of drugs used for this purpose are antidepressants, antipsychotics, mood stabilizers, anti-anxiety medications, and sedative hypnotics. Chemical restraints are incredibly dangerous. Using powerful psychotropic drugs has clear risk on a person's physical and mental health and should only be used when absolutely necessary. Because the elderly are often taking more than 5 medications already, the risk of harm is greatly increased when you have polypharmacy, which means multiple medications that they're taking. According to the FDA, unnecessary use of antipsychotic medication kills 15,000 nursing home patients every year. And the federal government has spent years warning facilities about their dangers, especially the damage they can do to the heart and cardiovascular system of somebody, especially in dementia. But despite these warnings, more than 88% of the antipsychotic drugs used in nursing homes are used on patients who have dementia. The risks and harmful effects include increased dependence and functional decline, loss of memory, it can actually make that worse, agitation, withdrawal and depression, orthostatic hypotension or low blood pressure, loss of mobility and strength, increased risk of accidents and falls, low blood pressure, muscle disorder, and other adverse drug effects. Now, physical restraints over the last 10 to 15 years, medical research has produced strong evidence that restraints do not prevent injury and may, in fact, present a safety hazard for the resident. So these findings, combined with a heightened concern about the quality of life in nursing homes, have prompted a re-examination of past practices regarding the use of restraints. And a national effort is underway to reduce the use of physical restraints in nursing homes, and that caregivers have been actively seeking alternatives for ensuring the safety of residents. What are the dangers and outcomes of the use of restraints? Despite standards aimed at minimal or no restraint use, approximately 15% of nursing home residents and 6 to 17% of patients in acute care settings spend a portion of their day in restraints or confined inappropriately by side rails. Among older patients, the incidence of restraint use is higher. It increases to 18 to 20% among those 65 years or older, and up to 22% for those aged 75 or older. Of older patients who fall, 13 to 47% are physically restrained. Serious injuries from falls are greater when the person has been placed in physical restraints. Among restrained patients, 20 to 50% demonstrate significant depression, agitation, confusion, withdrawal, or anger as a result of restraint use. There are morbidity and mortality risks associated with physical restraint use. Short-term complications include new onset bowel and bladder incontinence, constipation, decreased appetite, pressure ulcers, muscle weakness, injury to nerves and joints, and pneumonia and respiratory complications. However, there are more serious complications too, such as death from strangulation, head or body entrapment between bed rails, mattress, and footboard can occur because the persons who are restrained are those with altered mental status, restlessness, confusion, lack of muscle control, or a combination of all. The adverse psychological effects of restraints include anger, aggressiveness and agitation, demoralization, humiliation, feelings of low self-worth, depression, impaired social functioning and social isolation, feelings of shame or guilt, loss of dignity and self-respect, and a loss of autonomy. There are many benefits of eliminating restraints, and this includes greater autonomy, improved quality of life, even reduction in the use of antipsychotic medications, a reduction in the seriousness of injuries due to falls, and of course, reversal and improvement of the many adverse effects that we mentioned before because of improved mobility. So let's look at some of the myths and misconceptions about the use of restraints. So it used to be thought that using physical restraints prevents the elderly from falling or injuring themselves. But the truth is, no scientific research supports the assumption that restraints protect the elderly from injury. On the contrary, research indicates that restrained residents were 3 times more likely to be injured during a fall or related incident than unrestrained residents. Another myth is that restraints, when properly applied, won't harm the patient. However, even when properly applied, restraints can lead to serious complications, especially related to immobility. Another myth is that because the mental status of many restrained elderly patients is altered, they don't suffer negative psychological effects from being restrained. However, many elderly patients report having felt fearful, demoralized, humiliated, angry, uncomfortable, and confused. And these feelings, in some cases, persisted for months or for years after they were actually restrained. Another myth is restraining an agitated elderly patient will decrease resistant behavior. However, the fact is that restraints can actually trigger resistance and agitation in the elderly. Attempting to restrain a disoriented, fearful patient may increase his panic and make him combative. It used to be thought that restraint-reducing programs require extra staff and that they're expensive and there's all these complex interventions. But the fact is, when they are properly implemented, restraint reduction doesn't demand an increase in staff and can actually be cost effective because of fewer patient complications and a lower morbidity rate. Something else that people may believe is that the failure to restrain puts individuals and facilities at risk for legal liability. But the truth is that federal and state regulations restrict use of physical and chemical restraints for nursing home residents. The Joint Commission guidelines limit the use of restraint and seclusion to hospitals and other healthcare facilities. As usual, there are exceptions to these rules. If a resident needs emergency care, restraints may be used for brief periods to permit medical treatment to proceed, unless the facility has a notice indicating that the resident has previously made a valid refusal of the treatment in question. If a resident's unanticipated, violent, or aggressive behavior places him or her or others in imminent danger, the resident does not have the right to refuse the use of restraints. In this situation, the use of restraints is a measure of last resort to protect the safety of the resident or others and must not extend beyond the immediate episode. The facility may not use restraints in violation of regulations solely based on a legal surrogate or representative's request or approval. If the assessment team recommends the use of restraints, a physician's order will be needed and informed consent. The team will explain why the restraint is being used and how the restraint will be effective in treating the specific medical symptom noted in the physician's order. Potential risks posed by the restraint will also be described. The restrained individual will be under regular observation and will have adequate opportunities for movement and toileting. A plan will be in place for eventually phasing out the use of restraints completely, or at least finding the least restrictive form of care that will meet the needs of that particular individual. The staff will monitor the resident for common side effects of restraint use, such as increasing weakness, other physical effects, fear, agitation, and depression, and staff will be prepared to address these problems if they occur. Now, every time a restraint is used, it opens up the facility to litigation. So we're going to talk a little bit about the legal and legislative aspects of physical restraints. The Center for Medicare and Medicaid Services dictates that the resident has the right to be free from any physical or chemical restraints imposed for purposes of discipline or convenience and not required to treat the resident's medical symptoms. The intent of this requirement is for each person to attain and maintain his or her highest practicable well-being in an environment that prohibits the use of restraints for discipline or convenience and limits restraint use to circumstances in which the resident has medical symptoms that warrant the use of restraints. If there is litigation, then there are legal procedures in place, and they will need to determine if the facility follows a systematic process of evaluation and care planning prior to the using restraints. Now, since continued restraint use is associated with a potential for a decline in functioning, if the risk is not addressed, determine if the interdisciplinary team addressed the risk of decline at the time restraint use was initiated, and that the care plan reflected measures to minimize a decline. Also, they will try to determine if the plan of care was consistently implemented. They will determine whether the decline can be attributed to the disease progression or inappropriate use of restraints, and they will need to determine whether the facility used the restraint for convenience or discipline, or a therapeutic intervention for specific periods to attain and maintain the resident's highest practicable physical, mental, or psychosocial well-being. If there is litigation, then the following needs to be documented, and we can't say that enough. Document, document, document. Number 1, what are the medical symptoms that led to the consideration of the use of restraints? Number 2, are these symptoms caused by a failure to meet individual needs in accordance with resident assessments, use rehabilitative restorative care, provide meaningful activities, manipulate the resident's environment, including seating? If the cause cannot be eliminated or reduced, Then has the facility attempted to use alternatives in order to avoid a decline in physical functioning associated with resident use? If alternatives have been tried and deemed unsuccessful, does the facility use the least restrictive restraint for the least amount of time? Does the facility monitor and adjust care to reduce the potential for negative outcomes and continually trying to find and use less restrictive alternatives? Did the resident or legal surrogate make an informed choice about the use of restraints? Were risks, benefits, and alternatives explained? Does the facility use the care area assessment to evaluate the appropriateness of restraint use? And has the facility reevaluated the need for the use of restraint, made efforts to eliminate its use, and maintained resident strength and mobility? Now, there are many alternatives to physical restraints, and the care goal for any long-term facility should be to foster a restraint-free community in the nursing home or assisted living residence. So the assessment here is very important. Using assessment to find out each resident's life history, habits, and preferences is critical to restraint-free care. Ongoing assessment is an essential strategy for identifying use of restraints and alternatives to their use, as well as to support restraint-free care. Residents need regular, comprehensive assessment so that their individual care plans addresses needs and prevents the use of restraints for different conditions. For example, some medications can cause dizziness, loss of balance, or delirium. Others can reduce psychotic symptoms and the perceived need for physical restraints. Now, the key to eliminating the use of restraints is individualized care, which really depends on staff knowing the resident as a person. Consistent assignment of staff to residents promotes individualized care. Effective care planning really involves knowing a resident's remaining abilities and understanding how to make use of them to avoid conditions such as wandering and falls that can lead to inappropriate use of restraints. Care planning staff are responsible for trying and documenting various options to avoid use of restraints. Staff at all levels need to understand the hazards of using restraints and the process of individualized assessment and care planning to meet each resident's unique needs. So let's look at some examples. Respond promptly to resident calls and minimize their wait times. When residents repeatedly slide out of their wheelchairs in an attempt to self-propel, place them in lower height wheelchairs without footrests or with footrests in the closed position that allow their feet to touch the floor. Assign staff to identify and help fatigued residents go to bed when they need rest so they won't attempt to go into bed unassisted. Use individualized day and nighttime activities to increase resident contentment and decrease behavioral symptoms. Seek assistance from a professional to help reduce use of restraints through evaluation and treatment of physical, cognitive, or sensory impairments. Camouflage and protect areas of active wound care so the resident will not disturb dressings or the healing process. Encourage family members and friends to sit with the resident and provide support or reassurance. Use pads and pillows to support comfortable and safe body positions. Adapt and tailor chairs to ensure comfort and safety. For wheelchair use, ensure that it is the correct size, comfortable, and in good condition. Respond quickly to physical needs such as hunger, thirst, sleeping, toileting, and exercise. Tailor care and caregiver assignments to residents' preferences. Provide therapy and restorative care to improve residents' abilities to stand, transfer, and walk safely. And help residents get in and out of bed as often as needed and desired. Methods to improve safety of all residents include increased staffing levels to improve supervision. Adapt the environment through good lighting, safe beds, alarms, and other features. Remove accident hazards such as overbed tables with wheels and cluttered dining rooms. Provide safe areas for the residents to walk. Train staff on methods to calm patients who are anxious or agitated and to identify and address unmet needs. Arrange mental health treatment for residents who need it. So let's look at some products that can be used as alternative to physical restraints. Number one would be a disposable Freedom Splint. And most of these honestly can just be found on Amazon. So the disposable Freedom Splint restricts arm movement without rigid arm splints. The next picture is called a self-releasing lap hugger. This soft lapped cushion fits snugly between the resident and the wheelchair frame to facilitate upper body positioning and helps prevent forward leaning. The next product is a chair wedge anti-slide. And this can be used as a non-restraint product to help prevent people from sliding off chairs. The next picture, which I really love, is a bedfellow positioning roll. This can be used to improve hospital bed safety or in a chair, and it provides full body support in lateral or dorsal positioning and can be placed around the patient in a chair also to correct side leaning. This is called peekaboo mitts. They are designed to prevent residents or patients from removing medical equipment like IVs or devices to read vitals. Now, sometimes alternatives consist of simple material goods that you can buy anywhere, and sometimes they're more a matter of dealing with a client and meeting their preferences. Sometimes something very simple just has to occur for you, and sometimes different products need to be combined in order to form a good alternative. In conclusion, providing safe care for individuals with physical and mental limitations is, of course, a universal concern. But safe care can be provided without applying physical restraints, which unduly restrict freedom and create other serious risks. Self-care can be ensured through the use of alternative safety measures, which can be tailored to meet an individual's specific needs, ensuring the best quality of life. Facilities that have dramatically reduced physical restraint use have not experienced an increase in serious injuries and have seen marked decreases in the incidence of agitated behavior among residents. So reducing the use of physical restraints is a national goal which is being promoted by caregivers from all segments of the healthcare team. The motivation behind this goal is enhancing the quality of life of nursing home residents while assuring safety. The payoff will be much better and more appropriate health care for individual nursing home residents who will be spared the indignities and harmful effects of unnecessary restraints. So I want to leave you with some tools. There's a website and it's called nursingHomeToolkit.com. And this is a toolkit for reducing antipsychotic use in older adults. And they do it by promoting positive behavioral health. And this can be accessed online. There's also another website called hospitaleldrlifeprogram.org. And this is non-pharmacological strategies for hospitalized older adults and their caregivers. And this can also be accessed online. Thank you for joining me today. Now, we all want to improve the safety and quality of life of our elderly residents. So hopefully this has provided you with helpful information of how to create a restraint-free environment. I hope you have a wonderful day. Stay safe and stay healthy. Thank you.